Good afternoon. It is my great pleasure to welcome you at this Qatar Symposium. My name is Bert Hofman. I'm the chair of epidemiology here at Harvard Chan. The Qatar lecture, or the Qatar Symposia, have been held since 1912 under the terms of the bequest of John Clarence Qatar, a graduate of Harvard Medical School. It is the oldest lecture series in epidemiology and preventive medicine worldwide, and it's always been presented under the auspices of the Department of Epidemiology, first when it was part of the medical school, Harvard Medical School, and since 1942 as part of the Harvard School of Public Health. This is the 9th Qatar Symposium, annual Qatar Symposium, and we have 3 speakers, Issa Dahabre, Stephanie Friedhoff, you see them here, and Alfredo Morabia. They will discuss different but complementary aspects of medical information and misinformation and the role of epidemiology thereby. Each will have about 30 minutes, and then we have, after each speaker, I propose a brief Q&A, and at the end, a general discussion. All right. First speaker is Dr. Issa Dahabre. He is associate professor here in epidemiology at the Harvard Chan School. He is also, he's particularly working with us on transportability issues and other issues in epidemiologic methods, but here he is as basically in his function as methods editor of the Journal of the American Medical Association. Dr. Dahabre will speak about causal inference and causal language for observational studies in medical journals. Issa Dahabre.
Hello, I'm Issa. So, first, some disclaimer I think is in order. I noticed on the program my work as an editor, statistical editor at Zama is featured, and Bert mentioned it. It's not obvious when I'm Issa, the faculty member here, and when I'm in my role at Zama, and so I wanted to propose the following deal. If I say anything controversial, that's Issa the professor, okay? Anything unoffensive, it can be attributed to either. So we need to have that agreement. And certainly, you need to know that I cannot speak for the AMA or the journal as a whole. I'm just one of many, including many statistical editors. We now have a senior one and 4 others. Okay, and so that's one thing. The second thing is my topic is going to be causal inference and causal language in observational studies for medical journals. And I was thinking I would start with some kind of joke, maybe a little self-serving, about how I will talk about the information piece of the session, because in Zama there is no misinformation. But as I was thinking about it, I realized that perhaps my most interesting experience at Zama has to do with a very special kind of misinformation. And for lack of a better term, I will call it methodological misinformation. And the way this plays out, for the most part, is something that we, the people of public health, the people of epidemiology, the people of medicine, it's something we appear to be doing to each other. And so here I have obscured the name and the face from Twitter, X, I guess, post, where the poster very kindly summarized the BMJ Open, I think, paper that basically reviewed the use of causal language in publications in major journals in the BMJ, and then helpfully offered the following advice. If your data is observational, make sure your language is too, over there. And I even more helpfully copied from the paper a list of words that are danger words that may be taken to be causal. And I'm sure this person is well-meaning. It's not meant as a critique, but as an observation that this is quite prevalent and done publicly. Now, it's pretty clear that the people can tell which words are more causal than others, humans, I mean. This is a result from a systematic effort to extract linking words, things that appear in conclusions, and try to rate them subjectively into how causal they are. And so I copied the very bottom of the ranked list and the very top of the ranked list. And you can see some words are, almost universally believed to be strong or moderately causal, and that makes sense. The word cause seems to be causal. But then, other words that you would think are kind of innocuous, like the word one thing is associated with another, even those can sometimes be viewed as somewhat moderately or even strongly causal by some of us. So there is clear discrimination. The top and the bottom of the table looks very different, but there is also room for judgment. And it's useful to know, I think, that humans can tell the words apart, that we think they have different connotations because the machines are learning from the humans. And so I thought in preparation for this talk, I would ask Google, which now is really Google Search Labs AI at the top, and then the rest of the old school Google. I asked it, tell me about causal language. Just type causal language in, and it says, reasonably innocuously, I think here, that causal language refers to the use of words or phrases that imply cause and effect, and then suggests that maybe there's good reason to be careful, and that sometimes non-causal words are useful. And as I was saying, if the people can tell the words apart, the machines can tell the words apart. And so very helpfully, the Gemini engine says that here is 3 examples of causal language, and they make sense. They agree with the table we saw before, and a much longer list of non-causal alternatives. In fact, in my version of Google, the list of non-causal alternatives kept going. I just cropped the top. Okay, great. So the people and the AI know that the words have meanings, and they can tell them apart. But where it starts to get, I think, interesting and very relevant to my subject, my main subject, is that by studying us, the machines have learned to connect language with study design in a rather direct way. So without me asking anything except causal language, without me prompting in any provocative way, the machine thought it useful to say, when strong evidence supports a causal relationship, and that's usually in well-designed randomized controlled trials, that's when you can use causal language. And then in the same search a little further down, it warned me to avoid misleading claims, and you can see JAMA is starting to appear as a party to blame. So we also say that the use of the language should be restricted. And in fact, I traced one of the AI links, and it took me to a set of slides that's posted online at the Stanford University website, but it is the slides from a talk that one of my colleagues gave in 2019 before the initiative I will talk to you about today. So you can see here, this is definitely my people. And up here, I don't know if it's ever been done to you, that people went through your pre-publication proof and changed the words that you had into other words that were associational. But this, and I'm not sharing any secrets, this is now posted online on the internet. So we're just looking at something that's out there. Clearly, there was, in 2019, talk of trigger words, where if you see them, if the copy editor saw them, they were to use the replacement words on the right. And you can see effect is to be replaced by association, efficacy is to be replaced by association, anything that has to do with increase, decrease, is to be converted into a periphrastic associational thing. And then you can see the right-hand side is almost all associations. And certainly there is a big no-no of replacing effect with other potentially causal words. And so this was, I think, being done internally. Okay. I will say there were some exceptions allowed later in the set of slides for things like Mendelian randomization, arguably, like where you shouldn't change it if you ask me, but very few exceptions allowed. In general, association is the preferred word for non-RCTs, as you can see. And it is to be done everywhere, in the abstract, in the methods, in the results. The other thing that I noticed is somehow the PDF I was studying for the history of my people at JAMA, the PDF had mention of EBM, evidence-based medicine. And I thought I couldn't miss out on the opportunity to talk about a related bad idea of EBM, and that's the evidence pyramid. And there's this person who very helpfully, cite them at the bottom, they very helpfully trace the origins of evidence pyramids as early as 1997. And so someone in 1997 took a list of study designs from an EBM textbook and made this beautiful, colorful pyramid. And first of all, there's an interesting thing that ideas, opinions, editorials are better than experiments in labs or animals. That I think is cute. Definitely reflects the doctor's own opinions of their opinions, I feel. And then if you go at the top, you can see randomized, controlled, double-blind, very specific design element is near or at the top. And there is some allowance. This is very early. This is 1997 or earlier. There is some mention of systematic reviews and meta-analysis. As the business of EBM has grown, the activity of EBM has grown, you can see that RCTs and everything else is pushed lower down, and we get more summaries up at the top. But basically, once you look at original investigations, still the RCTs at the top. And I mentioned this number one because it seems to me to be a very related bad idea. It's the idea that somehow, in a context-free way, you can look at the study design and immediately decide the relative quality or evidence weight or importance of a piece of research. And of course, EBM has a long history in JAMA, so maybe it's not a coincidence. Now, currently in JAMA, this is our, to this day, official position. And so if you go to our instructions to authors, it says causal language, including use of terms such as effect and efficacy and so on, should only be reserved for randomized trials. And for everything else, it's associations. And this criterion, which I sometimes refer to as the randomization-centered criterion, you're looking at a single design element to decide what language is allowed, is reflected in the AMA Manual of Style. And through that, it has influence on the entire JAMA network and beyond. Okay, so we know it's bad. I always say at this point that the initiative that I will describe now about rethinking the policy about causal inference at the journal is really an indication of the leadership of the relatively new editor-in-chief, Dr. Bibins Domingo. I just happened to be there, maybe know a little bit about the area, and I offer technical support. But the way this is possible is because the journal leadership realizes that we have an untenable situation in our hands. And so what we did about that is the editor-in-chief and myself, we published what we call a special communication. This is some mix of opinion and evidence-based information. And the reason we made it a special communication and not an editorial was to make sure nobody mistook it for the actual policy change. So that's how it started as an editorial, and it became a special communication. But the reason for that is that we perceived in our early discussions about this some degree of resistance, for lack of a better word. Some people didn't feel very comfortable about the change. And to make sure, again, nobody mistook it for a policy change, it was also accompanied by what we call an editor's note, which explained that we're really thinking about it, that we want to hear from readers, that we will, and I have been assigned to lead that effort, we will publish follow-up pieces to try to make the framework that was in the special communication more practical. And so at this point, I assume no one needs to have spent time reading, 7 pages of dense basic epi. That is really what is the special communication. And so I will summarize what we wrote about. And it's important to be very clear about the scope of what we wrote about. So we wrote about observational, call them non-experimental, studies of interventions. So treatments, policies, things like that, in groups. And we only wanted to talk about them as potential, independent, and I use this informally in the sense separate, sources of evidence about causal effects, which we took to be the effects of interventions. Now, in case someone thinks this is everything about causality, I know Miguel thinks this is everything about causality, it's useful to say what we did not write about. So we did not write about the very important question of does something, a factor, an exposure, X, cause Y. In fact, I think the word cause appears in the paper only once, and only in the place where we say we will not talk about causes of things. We just talk about the inference about the effects of interventions. We did not talk about mechanisms in that piece. Anything that has to do with the process, the mechanistic understanding of how something brings about something else. We also didn't talk about things that very importantly can lead to big insights about causality, especially in domains like infectious disease or unique new environmental exposures. So case reports, case series with unusual exposures or presentations. We just didn't have the ability to write about that, but it's not to say that it doesn't have value and it's not used to infer things in practice. We also did not talk about whether one design is better than another. We did not mean to say RCTs are good or bad, observational studies of some kind are good or bad, or anything like that. And also they always want me to put this last bullet because at some point it was perceived that even the existence of a piece about causal language from observational studies may cast doubt in the journal's passion and love for randomized trials. So JAMA still loves randomized trials. If you have a big one, we'd like to see it. A good one, a unique one, we want to see it, and it's still true. We love them. Nothing like that. Okay. And so we basically gave 3 arguments, or we examined 3 arguments for allowing causal language for observational studies. The first is that research questions can be causal because a research question is what the person is interested in. And as such, whether a design or data source or anything like that can provide relevant answers or evidence is unimportant. What matters is the question itself. And so you can be interested in the causal effect of some treatment on some outcome, regardless of design or data. Then the assumptions and methods, we said, can be causal because appropriate methods can only be chosen and critiqued if the research question is clearly articulated. And so the idea is if the question is causal, then by necessity the assumptions and methods to be used will be causal. The third argument, and perhaps the more controversial one, is that in some cases, causal conclusions may be drawn under assumptions that one wants to be very clear, and if appropriate methods are used on very rich data. And so this is the third argument. Okay, so I feel, and perhaps more so in this audience, the first two arguments are very natural. The use of causal language for specifying the research question, for debating assumptions, for selecting methods, seems almost uncontroversial to me. Because, if anything, we get to observe the opposite in the manuscripts we review. In what we review is people are using associational, so non-causal language, and then routinely in their limitation section will discuss confounding. So this seems to be perverse. How would confounding matter for pure associations? And so if anything, people are going the other way. They're using causal critiques for ostensibly non-causal questions. But more generally, for the question specification and for stating assumptions and describing methods, it seems that the issue is one of accurate and transparent communication. You just need to say what you are interested in and what you're going to do to find out. And people should, we think, have the freedom to express that interest, the causal interest, if they have it. Now, causal language for conclusions is certainly more controversial. And I want to try to pinpoint why it's more controversial. And so we thought the problem is the heavy reliance on uncertain causal assumptions, particularly when compared with some ideal situation of a very large, well-conducted, randomized trial. For instance, many causal methods, and again, this audience probably doesn't need a reminder, but many causal methods rely on untestable assumptions that there is no confounding or that there are variables with special properties, let's say instrumental variables, or other similar unique aspects of the system under study that justify the drawing of causal inferences. And so if all other things were the same and you were comparing between an observational study that relies on uncertain causal assumptions and a large, well-done trial, it would appear normal to think that the observational study is inherently more speculative. The problem is all other study aspects are often not equal. Trials are not feasible for many, maybe most causal questions, and even when they're feasible, they tend to be done once or twice or a limited number of times in special selected populations, and so they don't generalize well, and always there is open questions that remain unanswered. The other thing that we thought is problematic is elevating a single criterion as the criterion of quality is problematic, because in our deliberations at the editorial board, when we discuss randomized trials, we don't just say, oh, it's randomized, must be really great, let's accept. We think about all other aspects of the design and conduct of the study. So similarly, it's not clear why a single criterion would be logically enough to reject observational studies as a source of separate independent evidence for causality. And in fact, there is history here, and obviously I have selected things that I am familiar with, and a lot of it is done by people I like and work with. But I'm sure all of you have in your minds cases where observational data very persuasively was used to draw causal conclusions. Smoking and lung cancer, many advances in the treatment of HIV, resolving discrepancies between trials and observational studies for heart disease among postmenopausal women, and maybe more recently some completely implausible results about the ability of statins to help people with cancer. Extreme magnitude of effects were explained away using better methods or better data. And so in view of this, we thought that for some parts of the manuscript, for sure, some causal language should be allowed. And then we said that maybe there is a need for some framework. Now, anything I write here cannot be original. People have been thinking about frameworks for systematically, in a structured way, thinking about causality since forever. Our only contribution here was to boil it down to a manageable list and maybe a list that uses terminology that wasn't completely offensive to clinical readers or clinically oriented editors. And believe me, I tried for a more technical version more than once, but this is what made it through. So we said that you start with thinking about the causal question, you think about what quantity, if known, would answer that question, and for this, I used up my first allowed technical word. So we said the causal estimate, you are allowed to have a causal estimate in your study. I had a fixed budget of technical words for the entire piece, so I was spending very judiciously. Then we said you have some study design, and this is where all the sampling ideas would come in, and you do it so that it supports your ability to answer your causal question. You have some causal assumptions, and these are usually encoded in some kind of causal model. And then you need to discuss how the observed data can be used to answer the causal question in principle and in practice. And in principle here, I used my second technical word, which is identification analysis. So you need to say about how you connect your causal estimate with the observed data. And my third and last technical sentence was the one talking about statistical methods. So you can use appropriate statistical methods to work back to your statistical estimate and then back to the causal estimate. And of course, you need some integration of what you did, some causal interpretation, and some justification of whether it is or not tenable. And then we said these things roughly would appear in your manuscript in reasonable places. So the causal question maybe would be at the bottom of the introduction. Your methods would address items 2 through 5, and maybe the discussion is where you would go more into interpretation of your statistical analysis as estimates of causal quantities. And then the last thing we did in that piece is we drew out some implications. We said that we hope a framework like this will facilitate communication between authors, reviewers, editors, and readers. We identified some challenges in operationalization and implementation, and these were impressed upon us by our fellow editors. For authors, that they need to discuss and evaluate assumptions and openly acknowledge limitations. And to be honest, I think for authors, a framework like this is harder because you have to defend what you did and your conclusions without the ability to hide behind associational language. For reviewers and editors, that we need to do our homework and be ready to judge, to review papers that use specialized methods in the context of applied work. And then for readers, it's also going to be a challenge because there will be more complex concepts, more complex methodological descriptions, but that seems to be the easiest thing. We can always allow very long supplements. Now, I want to anticipate a couple of frequently asked questions about the framework. The first question I got from my colleagues, from the other editors, is how are we ever going to do all this in the limited time and the volume of manuscripts that we get? And there is this kind of question shows concerns about expertise among reviewers and editors, but also concerns about the nature of our own deliberations, like how are we, when we meet twice a week, going to think about all these difficult causal things? And the only answer I have found that works is to answer that question with another question. I just look them in the eyes and I say, have we ever published an imperfect randomized trial in JAMA? And because they all know that we have, they know how much we had to struggle to get the wording right and the interpretation right for that trial. And then they realize that the skills are, for a broken experiment, are pretty much the same as for an observational study. The second question that I get is, does this mean that people will always be able to draw causal conclusions? And the answer is no, and I think that provided people with some reassurance. First of all, I remind them that they know very well how to reject manuscripts. So if a manuscript draws conclusions that are not justified, they know what to do if the authors are not willing to cooperate. And then sometimes the journals can even publish notable failures. And so this is an example that I know Miguel often likes to discuss, and it's an example of screening colonoscopy versus no screening in Medicare data. And basically, just by looking at the results, doing a lot of attempts to control confounding and just finding implausibly large effects, the authors said, we just don't believe this. We don't think you can do confounding control for mortality outcomes in causal analysis using large administrative claims databases. And that seems to me a very nice illustration of being able to say sometimes it cannot work. And I know, and I will end with this, this is my very last story. I know everyone now wants to ask, would this ever fly in JAMA? Would JAMA ever publish a failure? And to show you that it can happen even in JAMA, I will share a brief evidence story in 3 parts. So you don't need to know all the clinical background here, but there is a medical device that's very interesting. You go in and you place it inside the heart, and inside the heart operates like a pump. And so there is the idea that for people who have cardiogenic shock, whose heart is no longer effectively pumping, you could use a device like that to prolong life, maybe give the heart a chance to recover. And so obviously there is a manufacturer that makes that device, and because this is an area of cardiology where very little progress has happened, for instance, the main comparator is the intra-aortic balloon pump that was from one of my professors in medical school in Greece, had contributed to the first study of that in dogs. So it's an old idea. There is no progress, so the FDA has allowed the use of this, and so one can get observational data about this device. And what's interesting, a group of authors here did deep work using registry, United States registry data, found very strong associations between the use of the device compared with the alternative and increased mortality. So a signal of harm from the new device. And then they had this very interesting conclusion in parent JAMA. They said we found an association with increased risk. And then they said that should be limited, the interpretation of this should be limited by the observational design. Kind of a difficult thing to square. This is before my time, by the way. I wasn't in the journal then. Because I don't see why an observational design would be a problem for looking at associations. But that is what they said. And so then this is a group I belong to from the Smith Center. I collaborate with them. And we studied the same device in Medicare data, but we found the same associations. You can see in our results also there is a 10 to 20% increase in risk from the new device, but the data didn't make sense to the doctors. Basically, we knew we were missing many important confounders. People who we know 100% received interventions were recorded as not having gotten them at all during the entire stay, which could never happen. These are strongly indicated medicines. And so we thought there's just inadequate control of confounding. And basically we said, we need assumptions for causal inferences. We don't believe, based on our background knowledge and the data we see, that they hold. And then we should give up on this data for the mortality outcome for this cardiac device. And this last sentence was heavily negotiated. There is some FDA co-authors. We said trials, but trust me, in the main text, we also say that very high-quality observational studies would also potentially be able to narrow down the space of interventions to study further. So we basically looked at the same associations, but concluded that you couldn't do it, not that there is harm. And so what's really cute, and this is the third part of and last of my evidence story, someone actually was doing the trial while us observational analysts were doing our work here in the United States. This was done in Europe. They randomized people to the device versus standard of care, and even in a relatively small trial, were able to show statistically significant improvements for mortality. And so definitely something off in the observational data in the registries as well as our own. And so just to summarize, it seems that sometimes, from the examples of others that I mentioned before, we can draw causal inferences from observational studies of interventions. It's important to maintain a certain degree of humility to know when we cannot. It doesn't seem to me, and I think most of my fellow editors, that this intentional methodological misinformation where we misrepresent what we're doing and hide behind associations is not the solution. And rest assured, the team at JAMA have recognized the issue and we're trying to do better. Thank you.
Dr. Garber, thank you very, very much. Are there technical questions? We have a bit of time for that. Any question or comment on this talk before we go? Yes, please. Yes.
Do you know if any other major journal has adapted a similar line of thought now that JAMA has published on this?
So,
about causal inference from observational data?
I am aware of at least 2 major cardiovascular journals that are rethinking their policies, in part motivated by JAMA's change. And then JAMA is in a family of 13 journals, so those are thinking. And some of the journals are very, very policy-oriented, so they told us very kindly that they held a small celebration when the piece came out. So in some places it will have influence, we hope.
I was interested by the fact that you mentioned the smoking lung cancer. It was published in JAMA in 1950. I think it was before your time.
It is before my time, yes. I'm old, but not
But it's an
much.
interesting case of an association that would not have been, testable using a randomized trial. So clearly you show it as a causal association, and still there was no way it could be shown with the randomized trial design. So in those situations, how does JAMA today respond if there is no option of randomized?
I think our attitude wouldn't depend on whether there is the possibility of a trial in terms of how we would think about the quality of a piece of work. I think it's good for us and the authors if there is a possibility to check later. But even in the case I showed where there is a trial, not everyone agrees that this is the correct effect estimate for the United States or for general unselected people. And so it seems to me one would go through the same steps to judge case by case. If there is a big lesson in the framework, a big message, which is not mine, other people have thought of this before me, is to do it case by case, consider what are the possible confounding factors, and take it from there.
Thank you. Dr. Darby, thank you very much. The second speaker is Stephanie Friedhof. She is a professor of the practice of health services policy and practice at Brown University, close by, and in that context here, director of the Information Futures Lab. It's wonderful to have you. Please discuss defending the science, losing the narrative, a path forward for health promotion in a chaotic information ecosystem. Please.
Thank you so much for that wonderful introduction. Let me just get set up here for a second. Here we go. Excellent. Are there birds in this room? Anybody else getting distracted from the nice bird sounds? As I said, it's great to be here with you all. And I'm going to make an assumption about all of us being here because we care about health for all, and doing that today and doing that in this year has become a little harder and a little different. And as we're thinking today about information and misinformation for this symposium, it has become obvious, I think, to a lot of people in this room that these increasingly chaotic information ecosystems that we have play a role in how doctors can treat cancer patients or how our public health workforce can engage with people around vaccines and STI prevention and other issues. So before I'm going to start my talk, I was actually hoping to hear from you. I know there's a lot of researchers in here, but Harvard, don't let me down. We can do this. If you want to pick up your phone, we'll put it away again. But I'd love to hear from you at this moment in history, and as we're talking about this topic, what comes to mind when you think about some of the key challenges that we have right now? So this is called audience engagement. We do this in communications. Disaster, I see. That's a good starting point. I'm going to give you all a second to log in so that we can see. In the meantime, I forgot to obviously thank Dr. Hoffman for the invitation and all my co-speakers. That was a fantastic talk, and I will be able to go through some part of my talk quicker because you've done some of the legwork already, so that's fantastic. So politics, distrust, lies, disentangling, knowledge, credibility, morality is in the room. Fake news. Yes, fake news is a different word for mis and disinformation. My colleague Claire Wardle actually created the renaissance of mis and disinformation and those words in a report as she was trying to get past the fake news language. So thank you for sharing these. Propaganda is on here. We will get to that. We'll also, Leo the Nines, wonderful. Let's do one more. What do you see as key opportunities? So if you're still logged in, it should also switch to this. Key opportunities. Now I'm a little confused about the lies. I'm going to ask about that in a second. Partnerships, collaborating. Yes, we will definitely talk about that. Morality is back. Yes, that is an opportunity. Truth. More people thinking about collaboration. AI is a big opportunity for you guys. I will extend my talk on that. Scientist influences, yes. Persistence, we do need persistence. Community empowerment, yes. Thank you. Okay, so the next and last one is going to be a little bit out of left field. I will not tell you why I'm asking you this question, and we'll get to that later. But the question is, did Elon Musk spend millions of dollars on Super Bowl ads highlighting government inefficiencies and why cuts were necessary, for example, at USAID? Don't overthink it, just put in your answer. Imagine you're being polled by KFF or Pew and they're asking you this question. Probably false, 47, probably true. Definitely true, 5, definitely 4, definitely false, 11, 10. Okay. Probably true. Everybody's thinking about it. Let's park the Elon Musk question. Okay, so I'm really excited to be here with you today. I was going to start with the measles epidemic. We're going to talk about information and misinformation, epidemiology, health promotion. There's a measles epidemic that started in Texas that is now spread across the country. And part of the concern that's on people's mind is social media posts such as these, which are both examples of disinformation in my view. You will see throughout the talk that I've blanked out the originators of those posts to protect their privacy. But the one on the left talks about, a very touching and heartbreaking story about a kid with autism and connects the autism to the vaccines. We all know that's been thoroughly debunked. The post on the right mentions a randomized control trial. This is an actual real trial. This is not fake. Sometimes these things are fake. This is not fake, it is true. However, the trial was between a placebo and vitamin A in children with measles in South Africa. That doesn't tell us anything about how vitamin A treatments would be comparing to a vaccine. So these are the techniques that you are all familiar with at this point of how some folks are trying to rope us into thinking differently, for example, about vaccines and about the measles epidemic. The concern then is, what is the impact of this information? What is the impact of this free speech in our information spaces? This is I got a call from a reporter. Lots of us got these calls. You know, there are these reports about vitamin A, toxicity. This definitely happened, but the question is, to what extent? The question is this an anomaly, like the couple that drank chloroquine after President Trump in 2020 said that it can protect you from COVID-19 and then died? Or is this a more massive harm that is being inflicted on society? That is really the key question. I'm going to talk about three things today. One is measurements and how we're thinking about measuring the impact of misinformation. Then I will talk a little bit about why I think we need to reframe this conversation, and then I'll talk a little bit about solutions from the practice. So what do we know about the harms caused by health misinformation? If we're so concerned about misinformation, then we should and would and want to understand why and how it impacts us. The challenge here, as I think the previous talk helps make the point a little bit, is that we have a lot of studies claiming that misinformation does X, Y, and Z, but the evidence base really is not very clear. And this is just one of the studies. There's different ones. One is called "Is Misinformation a Problem?" ? The challenge is big and consequential, and that is why scientists from all kinds of different disciplines are studying it. Computer science, communication science, political science, behavioral sciences, history, sociology, and so forth. But the challenge is that the field hasn't really come together yet to, for example, agree on methodologies to use. There isn't a typology of what misinformation is and those types of things. And as any behavioral scientist will quickly say, behaviors are complicated and they're never just caused by one thing. So creating a direct chain from I saw a post on the internet to action X is actually a long pathway. Like, you know, cognition, how am I even thinking? Is it impacting my cognition or not? Is my decision making based on what I know or on other emotional drivers and so forth? So I don't want to go into sort of all the science of this, but I wanted to communicate a little bit and summarize that as a field, we really do not have a good answer to this question of, you know, how does misinformation harm people and societies? And that's also an important question to ask. Harm in what? You know, how does it harm how we're thinking about things? How does it harm the actions that we take? And then collectively speaking, how might it harm sort of health outcomes in the long run? So let's look back at our measles example to see how that might be playing out as we're trying to understand in this specific case, as there is a lot of concern around the measles misinformation, what the impact is. So Kaiser did a poll recently. It shows that more people have been exposed to false claims that the measles vaccine is more dangerous than getting measles itself. So exposure, of course, doesn't tell us anything. It just means that more people have seen the claims. It's also interesting, given how widespread right now, we have seen an increase in coverage in general. It's low quality information, medium quality information, high quality information. So there's much more exposure, and as part of that, it makes sense that more people have heard about it. So then the question, of course, is, from having heard about it, or maybe I haven't, so some people who will have been polled here may not have heard about it. People are unsure about how to answer the question. I took a risk by asking you the question in the poll earlier. I didn't know what was going to come out, but what came out is exactly what we see on this slide, right? You hear about a piece of information or somebody asks you in a poll and you're like, I don't know, have I heard about it or not? It's really hard to be absolutely sure about something. And as scientists, we often expect people to be really sure about something because we're like, we know this works, or we know this is the reason. But people have busy lives by and large, and there's a lot of information that comes at us. So when asked these types of questions and when we interpret this type of data, it's really important to keep that in mind. Like, how are we coming to this question in the first place? And I'll talk more about the Elon Musk case in a second, because I haven't given you the answer to that question yet. So then there's other ways we can try to sort of chip away at the question of how do we know how this is impacting people? So what we can see is that 8 in 10 adults and parents say they're confident that the MMR vaccines are safe. And what's interesting about this is that this actually hasn't changed. So Pew asked a similar question about the risk versus benefits of the MMR vaccine in 2019, and then Kaiser redid that very same survey in 2022 because the pandemic had happened, because so much, the infodemic had also happened. People wanted to know what is changing here. And what you can see is that not much. By and large, the majority of Americans knows that the vaccine is safe and that the benefits outweigh the risks. What is changing, however, is how people are thinking about the mandates and how people are thinking about who gets to decide if I should take a vaccine or not. There are many reasons as to why that might be happening. One is that, people might be using different decision-making factors between identity. So, sorry, let me just rewind that for a second. One of the reasons why this might be happening is that we have, of course, seen an increase in leaders communicating concerns about the vaccine. So if you know that the vaccine is safe, but at the same time, your in-group is consistently communicating about the vaccine maybe, being problematic, it's easier to be against the mandate. It also aligns with conservative values of personal choice. So there are many different reasons and ways in which people respond to this type of information. And one way I like to think about this is that we're all a phenotype when it comes to these types of questions, because we bring our histories, we bring what we have learned, and then we engage with and hear information. But it is not a clear-cut sort of misinformation harms everybody the same way, or even we're not quite sure yet in which way, what type of misinformation harms people. We can also see this from the great latest survey. Gillian Steele-Fisher here at the school has done a tremendous service for a long time now, polling around trust and other issues in this latest survey that just came out, shows how much strong bipartisan support there is just for a number of key health concerns that people have in their lives. So while the world is exploding and there's signs in public health denial and a lot of concerning things are happening, we need to keep asking, is that, sort of the top extreme picture that we're seeing? What is actually happening in, these diverse publics that we have out there? We need a lot more research on this. And I'll give you one example from our work where we thought, great, the pandemic happened, we did a lot of things. We had an unprecedented investment throughout the pandemic. Let us take all the misinformation interventions that were actually evaluated. Let's do a review on all of those and take the lessons learned and turn that into practical tools for practitioners. Because the lab that I run is very much focused on how can we translate all the great work that scientists are doing for those who are on the ground right now, where people are walking through the door with misconceptions, with different ideologies, with all kinds of things. So what was so surprising about this process was that we identified 50 papers that we included in this study. We did not include any modeling. We wanted it to be any type of study that had involved real people. Most of them were experiments. The 50 papers covered 119 different interventions, so some papers would cover more than one. 50 studies, we found 47 different outcome measures. We could not compare the evidence in these studies. Only 18% of the studies that looked at COVID-19 misinformation, clearly a health issue, actually included any public health-related outcome measures. So these are the public health-related outcome measures that were looked at, and you can see here by the numbers how many of them did so. So a lot of the studies are a nudge on Twitter, and then can you discern misinformation in a different way, or how is your sharing behavior changing, those types of things. So this is in part a challenge that we all know science has a lot. It's like we study what we can study instead of where our questions are. And that is one of the challenges here. Among our recommendations were, at the time when we did this, there was no definition of misinformation. Without a definition, how do we measure anything? What was even more concerning is the examples, the stimuli. So the piece of misinformation that is put in front of people as part of the study is vastly different. It can go from gargling with garlic or salt water to full-blown conspiracy theories. So I would argue that it's such a vast difference in the kinds of stimuli that we need to question everything else that comes after that. And we're finding we keep doing this right now, and we're doing this, for example, for climate misinformation, for all kinds of misinformation. We're finding that a lot of the studies don't even include the stimuli that was used. So there's a lot of work to do. Since we did this, the National Academies convened a group of experts to create that definition of misinformation that we so desperately need. What they came up with is misinformation about science is information that asserts or implies claims that are inconsistent with the weight of accepted scientific evidence at the time, reflecting both quality and quantity of evidence. So really important measure here that we moved from early on in the pandemic, those claims about, this is definitely false information, to an understanding that science is per definition uncertain and that things change, and that we need to keep that temporality in mind there. Which claims are determined to be misinformation about science can evolve over time as new evidence accumulates. This also includes a definition of disinformation, which is a subcategory of misinformation that is circulated by agents that are aware that the science information they are sharing is false. I think Vish isn't here, so a faculty member here at the school was part of this commission. I know this was a really hard job to get to this consensus statement, so all of us in the field are really grateful for it. At the same time, if you ask me personally, disinformation cannot be a subcategory of misinformation. Disinformation is its own animal. And if we just think about misinformation as rumors and disinformation as propaganda, because it has that very clear manipulative aspect to it, I think we're losing something here. I also know that this was put out at a precious time in between the switch of the administration. So again, things to keep in mind as we are thinking about this. So the other thing that I like to stress is that people often say we're in a misinformation crisis, and I would argue that we're not. We're in an information crisis. And it's really important to think about and understand the difference. Now we get to Elon Musk and the Super Bowl ads. A colleague of mine at Brown had posted on his LinkedIn this, reportedly Elon Musk spent $40 million on Super Bowl ads, calling USAID wasteful. Here are a few ways I would spend the $40 million. Great list here. He runs the Data Science Institute. I'm like, man, you really did hard work. It's great, like all the evidence that's in here. I saw this on my LinkedIn. I brought this to class. talked with the students about how LinkedIn right now is really changing as a social space for conversations. And then one of the students in her reflection homework was like, I was at the Super Bowl, I did not see no such ads. So we had previously taught all the students, or I had previously taught all of them, how to do research on the internet. So she went on a deep dive and found that there was a lot of excitement in some communities about, people saying, I wasn't interested in the Super Bowl, but thanks to Elon, I'm all in now. Clearly, this needs to be happening. However, there's no evidence Elon Musk did not buy Super Bowl ads. And what we could see in our little experiment early on is that we're all predispositioned to believe that that is something that could be true because he's done all the other things, right? It makes perfect sense. It makes so much perfect sense. The student was 10 days ahead of the official fact checks, by the way, which I was very proud of. But what she also found is that there was this campaign out there by people supporting USAID who had used this moment on the internet and, the excitement and the virality of Elon is spending money on Super Bowl ads, is that good or bad, to communicate that very same information. So this is all the same list that my colleague from Brown had shared, and I realized, wow, I thought that my colleague had made the list. I didn't realize at that moment that this was part of an organized communications effort. The point of the story is, this is our life on the internet all the time. It has become incredibly hard to discern and understand what information is out there. We've gone from the world in which, and I don't know if you guys remember, I was one of the Twitter advocates early on. It freed up the internet. We had the Arab Spring. People could organize. So many good things happened. We went from that world to this world, where when Hurricane Katrina created havoc in a number of states, this kind of image started to pop up. In this case, with a message about, these victims needing help. However, it's very easy to identify that the image is AI generated and it is not real. There was a lot of misinformation around the hurricane specifically, and it was a good example of some of these dynamics in that at the local level, it didn't really make a difference. There was misinformation about FEMA is stealing money from people, and it was all very much directed at the then still in office Biden administration as part of the buildup to the election. But what is so interesting about this moment and puzzling is that when it was pointed out online that this photo is AI generated, people were like, yeah, I don't care. It feels real. This depicts my reality. So it's really important to understand these epistemologies, how we're making sense of things and how technology is changing our relationship with what is true and what is not true is consistently changing. And I don't know if it's increasingly driven by emotions, but it's very much driven by emotions. And we all have an emotional relationship with information, as we saw earlier in our Elon Musk example. You can also see here that the community, the new way in which we fact check information online through community is sometimes kicking in, often not. Lots to say about that. So we're in this moment where we have a lot of context collapse. That's the word that we use for the content was created for a specific context, and then it is dragged into all kinds of other places. So in this case, I haven't yet told you where did the rumor about Elon Musk spending $40 million on Super Bowl ads come from. It came from this gentleman who does satire on TikTok. So that's what started it, satire. Now, if you all paid attention to the news lately, this was also a joke that was, on the internet lately. So there's jokes that are getting taken out of context, and there is people playing with that culture right now in pretty significant ways. I was in the White House during the COVID-19 pandemic. I can tell you a lot about my frustrations with that time when one administration didn't participate in any of these spaces at all. It's clear that the current administration is knowing how to use the chaos that exists in our information ecosystem pretty well. We also need to acknowledge in this context, the outdated communications practices from public health leaders and that lack of humility that we have seen throughout the pandemic. So the evergreen tweet, right? If you haven't seen it yet, you must see it. You're not a horse, you're not a cow, seriously, you all stop it. That's how the FDA tried to get people in 2021 to be a little less interested in ivermectin. It's a condescending tweet. It was trying to be funny. It did not understand its audience. And then there's also the example in this case of, let's fact check. COVID is not airborne, which of course COVID turned out to be. And as Joe Allen, who was here at the school, would have told you at that time that COVID is airborne. This is something that we call the deficit model, where scientists continue to believe that there's just an information void in people and that we need to fill that. And if we just give them the facts, then everything will be fine. The opposite is often true because this type of messaging backfires. So it's much more than misinformation. People are engaging with content in interesting, in all kinds of ways. And one thing that we're seeing, if you haven't looked at the latest Edelman Trust Barometer, I encourage you to do so, is it's really striking and it's different from previous years in that, consistently all kinds of people left and right, it doesn't matter, fear that leaders lie to us all the time. We're losing trust, not just in institutions, we're losing trust across the board. What has happened to people on the right in the past is now happening to people on the left, which is that all of a sudden they're no longer trusting government sources because of who is in government. These types of erosions of trust are increasing and they're having real consequences. So, because in response, the behaviors that we're seeing is that people are using self-curated strategies to manage their information intake and crowdsource resources. That means that, as you can see from this one poll on the right here, we ask friends and families more, we look into specific groups, folks follow influencers instead of a traditional journalism source, all those types of things. People rely on who they know. That includes parasocial relationships. So that those are either, whoever here is young enough to watch TikTok or YouTube videos and develop a relationship with folks. This is a phenomenon that, of course, has existed since before the internet, that people build a relationship with celebrities and others. But there's an entire generation that has relationships with individuals on the internet. It also means that these tensions are arising between the ground truths that are established by authorities and those who establish knowledge outside of these traditional institutions. AKA, science says one thing, but in our group, we're saying another thing. Together, we're coming to different conclusions here in our community, and that is true for the anti-vax movement as well as many others. And all of this is the environment in which we now are trying to engage people around health. So while most people focus on that, top 20% of the iceberg, I would argue that it is really important that we understand this ecosystem of sense-making and knowledge co-production that's also increasingly moving away from traditional places of knowledge. That is not necessarily a bad thing. So if I should give one assessment of what went wrong in the pandemic, it is that knowledge was almost exclusively created and applied by experts instead of engaging with and generating knowledge with the public. So what do we do about all of this? How much time do I have? 1 minute. Okay. Almost. We do need to talk about solutions. So I give you one example. We did a pilot in Florida where we work with trusted messengers. What you can see there is that people have a ton of questions. So in just 6 weeks, we got over 500 questions. And questions are about, how do I get a mammogram if I'm underinsured? How much can a landlord raise the rent? And then you can see is the 2024 election still happening? This was before the election. So you can see that only 20% in this one study that we did, or one pilot that we did, had anything to do with mis and disinformation. The rest is people need answers. They need to know how to answer questions that are relevant to their daily lives. And in this work, we're also seeing, I'm not going to read through all of these, we often forget about the access elements of all of this, that quality information, like misinformation, is available in all the languages, in all the channel, with all the right cues, and quality information is often not. It's behind paywalls, it's designed for high speed, it doesn't use the right languages or cultural context, and so forth. So solutions have to start at the local level. This is from this pilot because we're working with Spanish-speaking communities. We knew that they were all on WhatsApp, and we shared lots of information on WhatsApp with them. We need more horizontal type of communication. What I mean by that, I'm hoping here people are familiar with the horizontal versus vertical framework. But we want to avoid coming in with, here's my topic, like I really care about stroke and now I need you to know about stroke. We need communication systems that engage holistically and sustainably. And then we ask just how does the issue that we want to help people with fit in their lives. That's really important. We need to build relationships, collaborations in a movement. That was in our opening slides here, the relationships and the collaboration. As public health is under attack, we need to, and we are building, I'm working with a large group of funders and others on building a movement for public health. This is from an Equity First vaccine initiative where we work with over 100 organizations across the country. What's important here is very few of these organizations have anything to do with health. We've expanded the public health workforce and we need to continue that. So these are, these are the churches, these are the food banks, these are all those types of organizations. We need to stop leaving the sense making to the bad actors. That was the science influencers that we heard earlier. We need to lead with empathy. This is a great example, right? When Nicki Minaj didn't know she was going to get vaccinated to go to the Met, some people started insulting her on the internet, right? Yeah, do you have scientists in your bedroom? You want you to do your own research. And Kizzy really showed us, one of the co-inventors of the mRNA vaccine, how to engage online, which is with empathy. So there's a whole list of these that I won't go through because we don't have time, but I wanted to share this one with you. We also did a study of how we are all talking about climate change and health online. As part of this, we coded how climate organizations and public health organizations, how they're communicating, what kinds of communication techniques they're using. And the majority of climate and health content online right now is doom and gloom. So we're not giving people any action items. We are not explaining what they can do. We all know that that usually turns people off, and there's no storytelling. So we have by far not enough storytelling in all of this. And I will close there.
Thank you very much for an illuminating and also very sobering talk, may I say. I think for the time's sake, we go immediately on and we can have questions perhaps in the general discussion. Third speaker, Alfredo Moravia. He is a recidivist because he was a speaker also at the first Qatar Symposium. He is a professor of epidemiology at CUNY and a professor of clinical epidemiology at Columbia, but is here mainly, I think, as editor-in-chief for another month, I understand, of the American Journal of Public Health. Wonderful to have you again, Alfredo. Please.
Thank you.
You will speak about epidemiology as a crossroads, history, misinformation, and the defense of public health, if your thing works.
So hello, everybody. Yeah, it's true. It's my second time. Last time was in 2013. And frankly, I was much younger because the room seems much larger to me. I had the impression I was walking around here, and but well. So I've done a lot of history of epidemiology and public health, and when Bert asked me to talk about misinformation and epidemiology, I was going to talk about how, along the line of what Issa presented, how epidemiology can produce misinformation. But actually, my experience over those last weeks, since January, has been different. It's been how can epidemiology and public health be forced to misinform? And I thought, I need to know, when this started and if there's a history of that. And so I've decided to modify slightly my title. And here is the type of experiences that I have had. I've received letter, in accordance to the president's executive orders as an employee of this federal administration. I'm writing to officially withdraw myself from co-authorship on all manuscripts on which I'm listed author. And those were already accepted manuscripts that were in press. And over the weeks, I've received many other letters. And they were asking for removing full articles because they were dealing with topics that are currently refused or not admitted by the current administration. They were asking to remove words in title, in abstract, in the text, authorship. And so it was really rapidly clear to me that there was no way I could answer to any, positively to any of those requests. It was a slippery slope. I raise a word, but what happens if the word is in the bibliography? I raise the reference, and then you erase all the reference related to those terms, essentially gender and equity. What happened to the people behind it? How does this lead to misinformation of the public? Disinformation, because some of it is clearly intentional. So I wrote this editorial in which I explained that it was just impossible for me as an editor to make any change on an article that had been already accepted for publication. This was equivalent to censorship. And I said, granting name removal or content modification on a case-by-case basis may turn into a routine concession, ultimately weakening the journal's role as an independent arbiter of science. So I took the liberty, Bert, to change slightly my title and to add, epidemiology at the crossroad, history, state-fostered misinformation, and the defense of public health. So I went back to some key moment in the history of epidemiology and checked, what had happened. What was the relationship between the government, the administration, and science? And I start here in immediately at the end of the Second World War. 1945, Hiroshima and Nagasaki. And during the years that followed, there was the Cold War. There was intense research on developing atom bombs, and there were actually experiments until 1963 that was done atmospherically, and they were exposing population. And after the 1963 partial nuclear test ban, I'm going to tell you about it in a moment, they were limited to underground testing. So it was really rapidly known, and I've checked the literature again in 1945, and after that, the radiation had important medical impact on the population in Japan. But the real epidemiologic studies that I really realized that now started in 1955, which is about 10 years later. And all the epidemiologic work is really on survivors based on a census of the Japanese population in 1950 and follow-up since then. There was the 120,000 people cohort called the lifespan study with a mortality outcome, a fixed cohort with followed, using mortality data and vital statistics, and there was a subgroup of 20,000 people which were examined regularly. What I want to say is that these data indicated relatively early that there were major consequences of being irradiated for populations. And, but the attitude of the government then was to try to downplay the risk. And there was a lot of attempt to calm the public and tell them that the bomb is not different, it's atomic, but it's still like regular warfare. And this was US News and World Report. The misinformation was not only about atomic bomb, as you can see, but they were attempting to convince the people, the population in the United States that being exposed to the radiation from the test in Nevada and elsewhere, which were radiating all over the country, was not a great health risk. And this Willard Libby from the Atomic Energy Commission, stated, the tone of the administration. The world is radioactive. It always been, and it always will. So there has been a lot of attempts to mask the potential impact, to keep the test. And I don't say that anything of this is not very serious and should not be criticized. But when you look overall, the secrecy went through classified memos, interagency agreement, implicit decision, funding of some studies and not of others, falsely reassuring the public. But you find no trace of executive orders, which would have, limited the possibility of federal employees to talk about these issues or to do research on these issues. And there was no penalization of universities which had anti-atomic researchers. And it was even possible to have a grassroots epidemiology movement, the Baby Tooth Survey, which some of you may have heard of, with support from the US Public Health Service. They sent questionnaire all over the country to parents who had babies who had lost their teeth. The teeth were sent to St. Louis, Washington University in St. Louis, analyzed for strontium. And in '63, they had 132,000 teeth. It was really a grassroots movement, to protect babies from the exposure of the atomic bombs. And finally, in '63, John Fitzgerald Kennedy signed the partial nuclear ban treaty. Barry Commoner, Bert didn't tell you, I'm at CUNY, I'm at the Barry Commoner Center for Health and the Environment, so that's why also I'm citing it. He's celebrating it as the first victorious battle in the campaign to save the environment. That's a little bit exaggerated, but certainly this Baby Tooth Survey played a role and was possible. Including with Public Health Fund. This is Barry Commoner, and you may know that this Baby Tooth Survey is now part of a cohort here at Harvard called St. Louis Baby Tooth Later Life Health Study. So that was for what happened in a very serious context of the Cold War, atomic bombs. There were a real separation between the administration, the politics, and the science. And everything that was done to misinform the public was done avoiding to do any pressure on the scientists themselves. The next moment, which is quite important on the history of epidemiology, is, the AIDS epidemic. In 1982, there were already 600 cases, and epidemiologists had really showed that it was not limited to gay and bisexual men. There were IV drug users, other populations. So it was clearly not a strictly gay-related disease. In 1983, the virus was identified, as you know, but this was the country. Since 1980, there had been a huge conservative movement electorally. The president was Ronald Reagan, and they didn't want to talk about anything that had to do with homosexuality or IV drug use, and so they just didn't mention it. And it took several years, until 1985, and the death of Rock Hudson, a friend of Ronald Reagan, from AIDS, to get some attention by the administration about the importance of the phenomenon and the need to do something about it. So 5 years later, here you have the total expenses, the federal funding for AIDS research. You see that until 1985, there was very little. And this was the AIDS epidemic affecting tens of thousands, hundreds of thousands of people, and a lot of life potentially saved. And then things started to change. So it's quite interesting to see that when they started to fund AIDS research, and they tried to put some limits in the use of that funding, it went through Congress. It didn't go through executive orders. The Helms Amendment, which said that the funds that were given to support AIDS research could not be used to encourage directly or indirectly homosexual activities, was a decision by the Senate and the House. It's been also judged unconstitutional some years later, but it was a law. The same when PEPFAR, this project about AIDS in Africa, that was adopted under the George W. Bush legislation. They had a part of it that said that 1/3 of all the funds had to go to support abstinence until marriage-related program. And this was still valid until 2008, when another act from Congress replaced it by balanced funding. But I say that because overall, when you look at the reaction of the government, which was very didn't want to do anything against the situation, thinking that it was limited to gay persons, there were delayed acknowledgement of the crisis, restricted funding for AIDS research. If the funding was not reduced, but it was allocated very selectively, discourage explicit reference to LGBTQ communities. Congress defunded programs that provided comprehensive AIDS education and condom, etc. But there were no executive orders. There were no legal interdiction through federal employees. And the CDC was very vocal during all this time period. And there were no penalized university which hosted AIDS research. So that was the second episode. Then there is a very interesting period here that when I went through all those years, I didn't notice then, but when I look at it again today, it makes us think a bit more of what happened. I called it here comes the presidential executive orders. And again, it's not, I'm not a legal scholar, and I may have missed something, but I really worked very seriously on that. And the first executive order that I could find that actually has implication for epi research was during the 93-2001 legislature, and it was an executive order to address environmental justice issue in minority population and low-income population. So it was an order which actually supported and promoted environmental and social epidemiology. And as you see, it says environmental human health research whenever practical and appropriate. This is important compared to what comes next. Shall include diverse segment of the population in epidemiological and clinical studies. So what's the difference between a decision by Congress and an executive order? An executive order can be rescinded by any further administration. It doesn't get into lasting policy. So it can be also rejected by a judge unconstitutional, etc. So it's a relatively weak form of government. And indeed, all those executive orders have been rescinded by one administration after the other. If you go to the administration from 17 to 21, there were really direct attempt by the administration to interfere with the activity of CDC. Paul Alexander, you may have known about him, a science advisor of the Department of HHS, said, CDC to me appears to be writing hit pieces on the administration. I continue to fight them. The report must be read before they go out and must be changed if they are going to hurt the president. So clearly, political interference with the science. But there was internal resistance at the CDC, which was possible. And the attempt to change the content of the MMWR was rejected by the editors. There was still a lot of autonomy by the scientific institution. In that same legislation, there was at the end of it a first executive order about the issue of sex versus gender, which has been, has come back in 2025. But immediately the next legislature with an executive order restoring trust in government through scientific integrity and evidence-based policing rescinded everything that the previous had done, etc. So we've entered in this time period a situation in which there is a battle of executive orders. And this is a very weak form of government and very not long-lasting. Avoiding the Congress in order to decide about policy implicating research is it's actually a very dangerous form of governing. So during that time period, there have been executive orders on both directions, promoting epidemiology, going against some forms of epidemiology, trending to control CDC, defending CDC, etc. Those 20 years have started a battle of executive order. One thing that didn't happen is attacking universities. And actually, the funding for universities have been going through all legislature, red, blue. It was increasing. The NIH funding was increasing very regularly. There was nothing like that. So we get to this year. And we clearly are in a completely different situation. There is a spate of executive orders like there's never been before. And those executive orders are about, currently mostly about DEI, equity, and about gender versus sex. And they are extremely constraining. It's the excise references to DEI and everywhere, including the grants, and this, you know what it means. Imposing a biological, this is also about DEI, but this one is imposing a biological truth about what is sex versus gender. You know, very intrusive role of the state. The elimination, the banning of hundreds of words from what federal employees can say and use. There was an attempt to it at the end of 2020. CDC had to remove a series of words from its vocabulary and from its website, but it came back much worse in 2025. And not only, and this is by nature looked at what types of grants have been removed, and you see that they are really topical, you know, HIV/AIDS, transgender, COVID, climate change, and this is also something new that we hadn't done before. In addition, medical journals are attacked. You know, what I showed you is linked with threats. You know, it's not that the journals may think that they are totally protected by the First Amendment. I mean, they are coming not only under scrutiny. 2 journals have been interrupted. Environment Health Perspective, a great journal preventing chronic disease, not a great journal, interrupted. MMWR is censored. And I know what I'm saying because those articles come to AJPH, and we've developed a new type of articles, you know, rapid report about public health intervention to try to still publish this material. And there's been those letters sent by an attorney in DC who was candidate to be Attorney General, and which was threatening us. And many journals reported publicly they have received it, others didn't, but there are a lot of other journals received, and it threatened the journals to remove the tax exemption that they benefit from at different level for the mailing and also for the association that support them because they were partial and etc. If they couldn't prove that they actually allowed different opinion to be expressed in them. So AJPH was really not the right target for them because we've been really producing bipartisan conversation over all the years. But these are real threat. It's not something you can take lightly. And then there is the dismantling of the health monitoring system, literally dismantling all our system of data collection. You have crimes about pregnancy and abortion stopped, lead poisoning, the whole section of CDC closed, environmental investigation, transgender data, violence, work, NIOSH closed, smoking and drugs, all the effort to get a real-time monitoring system that has been developed since COVID stopped. So we are in a completely different situation. It's a government, I consider it as a conservative revolution. We are facing, it's not just a few executive orders. It's a government that governs by executive orders with very little laws. There's interdiction for federal employees to perform research, specific topic, discuss them publicly, be authors on some specific, the universities are under attack, journals are interrupted and threatened, survey and monitoring system are dismantled. What there is not yet is deportation, incarceration, and murder. This is not there yet, but I would not, I think everything is on the table because the current administration with a very small Senate majority can only work by executive order and terrorizing the lawmakers that are supposed to vote for its action, okay? And they decided things that nobody would ever have thought, you know, that some nomination would occur. Nobody would ever thought in you know, in their noble mind that we would have some of the personalities we have now responsible for public health. Where we go from here? I have two examples that I think are relevant historically. I'll go very fast. But what happened when you have ideology that controls science? And there are two examples which are really relevant for what we are living today. The first one is what happened in 1948 in the Stalinistic USSR. There was this biologist, Trofim Lysenko, who believed in a form of neo-Lamarckism. He rejected Mendelian genetics, and he thought that traits could be acquired you know, by environmental exposure and transmitted hereditary. And so concretely, his idea was that if you took a seed and you exposed it to cold, you would train it to cold, and then you would plant it in the winter, and the plant that would come out of that trained seed would be also resistant to cold. Okay? That was opposed to what Mendelian genetics would say. You have to select specific seeds that seem to be more resistant to cold and breed them, etc. So he had these ideas which existed besides him. But and here you have Lysenko on the left and Stalin on the right. And what happened is that in summer 48, the Communist Party adopted Lysenko's views. And look how fast it goes. In the fall, they closed all genetics lab, biologists fired, genetic courses transformed. End of 48, you have no more Mendelian genetics in the USSR. The consequences on the yield, the agricultural yield of in the USSR have been huge, and with very low yield until the end of the 60s. So the fact that they try to impose ideologically one pseudoscientific theory because it looked closer to their interpretation of Marxism led to long-term dramatic societal consequences. The other example I have for you is even, you know, is very sad and dramatic, but it's, you know, in the case of USSR, it was the state against the theories, the scientific theories for ideologic reason. In Germany, during the war, it's been the state against scientists, not because of the science they were doing, but because of who they were. And in 1933, and look at the month and the speed, you know, in January 30th, 1933, Hitler is chancellor. A few months later, in April of that month, there is a law that says that non-Aryans cannot work in the state. You know, they had to be fired. Okay, and a month later, it includes all public and private universities, which meant essentially that Jewish scientists and doctors had to be fired, had to leave their institution, had no job anymore. And if you look at the evolution of the number of Jewish doctors, it went from 9,000 in 1933 to 0 10 years later. And during the same period, German medicine just degraded. You know, there is nothing, no contribution of German medicine during the 12 years of the Reich that is original, but has contributed something new. It was even short on vaccine against typhus, on DDT, and other very important medical aspects for their own wars. They became a tool of state racism and genocide in concentration camps. They perverted public health into a discipline of destruction And progressively, step by step, by sterilization, euthanasia, and final solution, they eliminated millions and millions of people in a specific part of the population. Physics lost 25% of its academic community. Jewish scientists, they left the country. But I put this expression, this sentence in German. I'm going to explain it to you. But when James Franck, who was Jewish and physicist, but was exempted by the law because he was a veteran of the First War, decided to resign in solidarity with his colleagues that had been forced to resign, they told him, es wird nicht so heiß gegessen, wie es gekocht wird. Nothing is eaten as hot as it's been cooked. You know, in the sense, this will not last. This will pass. It lasted 12 years, and it was just the beginning, and it was eaten much warmer, much hotter than it had been cooked. But of course, you know, Einstein left. He came to the US in 1939. He wrote a letter to FDR, and America had the atomic bomb before the Nazi, and they had stood up and beaten the fascism, and we're back to August 45 when I started my talk. But let's me give you my last few words. I think epidemiology is at the crossroad. We are really at the crossroad today. This is not against words. It's against who we are. And it's very deep. And misinformation impacts epidemiology when it comes from the state, and public health also, but it backfires. And it's the first time since World War II that we have explicit government-fostered censorship in the US, attempts to distort the scientific record. And where's the limit? You know, this is a slippery slope, and there's no real limit to it. So, as I said in my editorial, the current situation follows the same fundamental patterns as what we saw in Germany or in the USSR. Scientific findings are being challenged, not based on evidence, but based on ideological consideration. We must therefore consider what action, and I insist, however small, are necessary to counter tactics that creates a chilling effect on scientific discourse and ultimately risk to corrupt the integrity of the science. All right, this was my talk.